set up. So again, thank you for everyone joining. It's been a great experience working with each one of you. And also, Dawn, if you want to just talk briefly about the MDisability Summer Internship, that'd be great. Thank you.
Awesome. Thank you, Mike. Good morning, everyone. I'm Dawn Michael. I'm Disability Program Coordinator. I have been facilitating MDisability's second year summer internship program. We put a call out for applicants in December, and we had a great response this year, which was wonderful. Several faculty, family medicine faculty members were involved in the review and selection process of the 4 interns who are going to present today. That took place in February. So our interns were signed up for an live in-person experience when they decided to accept our internship. And of course, we all know COVID has happened, and we reached out to all of them and asked if they were still interested, if we could potentially come up with a virtual program, and they were all interested. And that interest, along with their flexibility, dedication, and commitment, engagement, all of it has remained throughout the 9 weeks of the program, and we want to thank you all for that. They've been wonderful to work with, and each of them have been assigned essentially based on interest and experience with a MDisability faculty mentor. This is the 9th week of the program, and so in the past 8 weeks, they've participated in weekly journal clubs with members of the family medicine faculty, as well as weekly mentor meetings with their faculty mentor and projects. Today, they're going to present those projects, their outcome of the work that they've done. So as Mike mentioned, we have an order. The first 2 co-presenters are Michael Casden and Samuel Crew. They have been working with Dr. Fermi Okunlami. And gentlemen, you're up. Thank you.
Awesome. Thank you, Dawn. I'll go ahead and present my screen now and get this presentation started. Okay. Oops. Sorry. Okay. If everyone can see me, I'll go ahead and get started. Hi, my name is Sam Grewe, and I'm here with my co-intern, Mikey Casden. And today we're going to be talking about 2 of the projects that we've been working on through this internship. And both of these projects are focused on increasing access to adaptive fitness and inclusive recreation opportunities for people with disabilities. Here's a brief overlook about what we're going to be talking about today. But at any point during this presentation, you can take a look at the ticker across the top of the screen to see where we're at in the presentation. Now, the disabled community faces many barriers that prevent them from facing a life of equality and inclusion. And these barriers result in many disparities, including lower socioeconomic status, lower rates of health screening, increased rates of unemployment, and even lower educational attainment. And perhaps the greatest one that often goes unacknowledged is just the barrier to fitness opportunities. And to address this issue, we first had to figure out what are the foundational barriers that are preventing people with disabilities from participating in fitness opportunities. And we found that it kind of breaks down to 3 main ones. And the first is awareness. This includes a lack of awareness from individuals with disabilities about existing opportunities that exist for fitness and for activities. And this also includes a lack of awareness from the general public of how important and underserved this problem really is. And the second is cost. Adaptive equipment such as racing chairs or prosthetics are often extremely expensive. And the third major barrier is accessibility. And this includes inaccessible facilities as well as inaccessible modes of transportation.
And so to address these barriers, we sort of had a main overarching goal for both projects. And that was, primarily to address these barriers, but also to improve access to inclusive fitness for people with disabilities. And so first we'll start by discussing our first project in the internship, which was titled Staying Fit While Staying Put. And then we'll move to the Michigan Adaptive Sports and Inclusive Recreation Initiative, which was our second project, which is ongoing. And moving forward, we will refer to that as a series. Also, to anyone who's calling in right now, I just want to recognize that we have a presentation and say if for any reason something needs to be clarified because you can't see, just please use the chat box, and whichever one of us isn't speaking will monitor that. So in terms of actually identifying this issue, we realized during the start of the COVID pandemic that the health and fitness community sort of adapted by moving online. And this was by, putting up video content of workouts, having workout classes as well, some subscription-based, some, that people were paying for. But we realized that, the people with disabilities were once again left behind. And so we wanted to create our own resource to make at-home fitness content accessible to people who had to stay at home. And that's where we sort of came up with Staying Fit While Staying Put, which was our online platform to consolidate fitness resources in order for people with disabilities to stay active at home. And so when we initially set out to begin the project, we had to consider, for example, the number of resources that we wanted to provide. There were tons of fitness resources, but also not that many specifically designed for people with disabilities. We also wanted to think about our target audience. And this was primarily because we wanted to make the platform as inclusive as possible. But we also understood that there's a wide range of disability and impairment that could influence, the workouts that people are participating in. And then we had to also consider the format that we wanted to disseminate this in, and so how this online resource would look, and the duration and scope of the project. So we wanted to get as much content out there during the pandemic, but we also wanted, this project to sort of be an ongoing resource, and we wanted to save some of that content or figure out how we could continue to post content, over the course of the next year or a few years and beyond. And so we set up sort of two sides of the project and the team. The first side was the content side, which was led by Sam. And I sort of led the website design side, which allowed me to interact with our unbelievable website design team within the Department of Family Medicine. So we really can't thank them enough for all of their help through this internship as well.
So in regards to gathering the content, we first started going through places like YouTube or hospital media libraries or even adaptive sports websites to begin sifting through and collecting content that already exists. Now, it was always a goal of ours to be producing our own content, but unfortunately we were also all stuck at home, and we could not safely put together a team to get this production going. But instead, what we were able to do is reach out to members of the U.S. Paralympic track and field team and ask them to record their own individual workouts that we would then upload onto our platform as a way to be creating new content that wasn't already out there. And with each new video, we made sure to collect all the relevant information and consolidate that in a spreadsheet like the one shown at the bottom of the screen so we could stay organized moving forward. And we also made sure that we were connecting with the content creators at each stage of the process. And this served a few roles. The first is that we wanted to obtain their permission to use their content on our platform. But in doing so, we made sure to emphasize the mutual benefits that would come from this partnership, especially in that we would post their content as a hyperlink on our website that would direct our users to the content creators' pages, ultimately increase the number of likes and views and subscriptions that they would be receiving. Another reason was that we often discovered additional content that we wouldn't have found otherwise, with many creators even offering to film their own or film new specific workouts if we were looking for something in particular. And the last is that reaching out with these content creators helped to really increase awareness in the disabled community of our website, because many of these content creators do have such big followings, and to have them share our platform would really get the word out that what we're doing is accessible. And when we finally collected a large library of resources, it became time to package them into usable weekly programs. And the goal in doing so was to maximize inclusion however we could. And we found that doing 5 videos each week with a mix of workout types targeting a wide range of disabilities and impairments was the best way to maximize inclusion. And so what we did was we packaged them in weekly formats like the one shown here, and that allowed for a very easy upload onto the website by our web design team. What we ended up with was an 8-week program that is now housed in the University of Michigan Family Medicine Department website within the MDisability tab. And this is where users can quickly scroll through the videos that we have and discern which are the most relevant to their needs based on the short descriptions that are provided.
And so we know that this project has already made an impact in the community, which I think is the most exciting part for Sam and I and all of the other team members that were involved. Just to give a specific example, we actually received a video last night from one of Dr. Okunlami's patients talking about how he used the resource and how it's been helping him stay fit and keep exercising while staying home during the pandemic. So that's just one of many examples and stories that we've sort of heard of people finding this beneficial, and really just an exciting sort of thing to be seeing at this point in the project. And so moving forward with this Staying Fit While Staying Put project, we created a succession plan, sort of recognizing that Sam and I might not be able to dedicate as much time that is needed to the project. So now a undergraduate student working with the adaptive sports program will easily be able to sort of take this over and continue posting new content as well. We're hoping that once our University of Michigan adaptive sports team comes back to campus, that they're going to be able to create new content, which was sort of a goal all along, but obviously because of the pandemic, we couldn't meet in person to film new workout videos. And we also think this will be a way to highlight our athletes, which is really exciting as well. And so while Staying Fit While Staying Put has sort of allowed us to address COVID-specific barriers, we also sort of in this internship and just as a, part of the MDisability program, we wanted to figure out a way to address the more systematic barriers that continually, limit people from accessing sports and recreation opportunities. And so the way that we sort of went about doing this is through our Michigan Adaptive Sports and Inclusive Recreation Initiative, a SIRI, curriculum. And so now we're transitioning to our second project here for those following along on the phone. And so once again, we see these barriers that Sam mentioned, awareness and cost, accessibility, also inconsistency in adaptive sports programming. And to address these barriers, we decided that we would, go and target children at a young age and create a curriculum, the ASIRI curriculum, to actually integrate adaptive sports programming into general PE classes. So the confusing part here that we've struggled with sometimes in explaining this to people, and I want to make very clear, is the idea behind this curriculum is that we will go into public schools and teach all students in their regular PE classes adaptive sports. That way everyone gets to learn and everyone understands what adaptive sports are, gets to play them, and hopefully changes their perception and becomes more inclusive.
So right off the bat, Mikey and I knew that we needed to collaborate with others who had more experience in many different fields. We knew we needed somebody who has experience in the schools, in the Michigan public schools, and we found that partnership with Project Healthy Schools to be exactly what we needed. Project Healthy Schools was started by a cardiologist at the University of Michigan in 2004 with the goal of implementing healthy lifestyles into local youth. And so their vast network of connections within the Michigan public school system allowed us to build upon that framework that already exists. And we also knew that since this was a K through 12 curriculum, we needed an educational expert to help us prepare the most efficient and usable format. And so we partnered with Elle Fraser, a current PE teacher and MD applicant, to put together a format that could be used by PE teachers all around. And we also partnered with Chris Kelly, who is a graduate student at the University of Michigan and an experienced wheelchair tennis player, to make sure that inclusion and accessibility was prioritized in every single one of our lesson plans that we put out. And so to gauge overall interest, we sent out a pre-initiative survey to local PE teachers, and we got some really valuable data to inform our future decisions. And I think the most notable that we found was that the majority of respondents either rarely or never integrate any adaptive sports or inclusive recreation into their programming. We also found that all respondents already teach sports like basketball, volleyball, and tennis, all of which we have adaptive versions already built into the Audiology curriculum. And excitingly, we also found that the majority of respondents were interested in partnering with us in the upcoming academic year and into the future to begin implementing this adaptive sports and inclusive recreation into their own programming. And so what this showed us is that this project is needed and would be supported by local teachers moving forward. So then it became time to begin formulating what the scope of this project would actually be. And so we decided to start off with a pilot project that would take place in 11 Ann Arbor public schools, and following a successful pilot project would expand to a total of 5 counties. And we'd start with Livingston and Monroe County. And that expansion is because that is where one of our partners, the Ann Arbor Center for Independent Living, already has branches. And this expansion would also include Wayne County in an effort to serve the overall underserved population in the Detroit area. And lastly, this expansion would include Ingham County. And there's 2 reasons for this. One being that that is where Michigan State is, of which we have a great relationship. And the bigger reason is that Ingham County is the home of Lansing, the state capital, which would help us implement policy changes on a statewide basis in the future. So as far as the curriculum itself, this is what the majority of our time was spent on. It's looking to be over a 200-page document just because it is so comprehensive. It's included in this curriculum is 10 different sports, and each of these sports is broken down into 4 different age groups, and that's K through 2, 3 through 5, 6 through 8, and high. And the reason that we chose to break it down into these age ranges is because each of these ages have specific developmental milestones that need to be targeted through educational standards like those seen at the top of the screen. And so along with these standards, we also included age-appropriate lesson plans that are both challenging and fun. And something that we deemed important early on in this project was representation. And we included celebrities or other role models who have physical disabilities to show these students specific examples of people who are finding great success with their disability, to really demonstrate just how truly capable individual with disabilities are, and to give examples that they can point to so that disability is something that these kids are comfortable with. And as far as disseminating the information itself, we are planning on employing a train the trainer model in which Project Healthy Schools and our team would be going into these local schools and actually training and giving demonstrations to the PE teachers so that they would then be prepared to go and teach their own students about this material. Now we know with COVID-19 that going into schools and even PE classes might not exist, at least not in the immediate future. And so to accommodate for this and to make this as comprehensive as possible, we set lesson plans that are able to be done entirely from home with little to no equipment necessary. And this includes a script that a PE teacher could read to their students via Zoom or call, as well as pre-recorded videos demonstrating these sports and teaching the lessons to students and staff without ever having interacting in person. McKee?
Thank you. Yeah, sorry about that, everyone. I was on mute. So I also just wanted to emphasize, this document and curriculum that we created will be a PDF and a web version, but to show just how comprehensive this curriculum is, it's over a 250-page document, really to make it specific to all grade levels, and really just sort of make sure that the teachers have what they need to continue on and teach it. But so to move forward, we've submitted for IRB approval, and we're hoping to conduct research on this as well to collect data about how teachers and students, how successful the curriculum is in sort of achieving our goals of changing perceptions. We also are setting up a equipment checkout. So students who participate in the curriculum, in the Ann Arbor Public Schools at least, can rent equipment for free and continue to participate in adaptive sports outside of their PE classes. And we would also be hosting a end of year camp with our adaptive sports team athletes. And this would just sort of be a way to, again, promote adaptive sports in the community and provide more opportunity for people to participate. And I'm really excited as well to be actually staying here during my gap year and continuing to work with Dr. Okunlami in implementing the curriculum in these schools. And so we just quickly wanted to highlight some of the additional work to show that, while we were working on these 2 projects with the adaptive sports program within MDisability, there is so much other amazing stuff going on that's really exciting as well, from other community programs, research projects that are now sort of being associated with the programs, and expansion with the adaptive sports team, having athletes come here on scholarship to the University of Michigan to receive an education and participate in adaptive sports. And finally, we just wanted to say thank you to everyone who was involved in making this program possible for us, especially with everything going on with the pandemic. So our MDisability co-directors, thank you so much. Special thank you to our faculty mentor, Dr. O, who couldn't be here with us today, our co-interns, and we also wanted to especially thank Dawn, who was just so integral to making sure this internship happened throughout the entire summer. So thank you, Dawn, and thank you everyone for listening. And now we can answer any questions for a few minutes. And to address Catherine in the chat, so the website has received a little over 250 hits as of yesterday. And the important thing I think about the website is that we are connecting people as well to, content creators that have their own platforms. So even if people aren't sticking around and continually coming back to our website, we feel that it's successful if, one person finds a creator who is putting out content that matches with their needs, and then they go and start using that person's content on their platform. So I think the stories to us have been what's, extremely rewarding in this work. You're welcome.
Are there any other questions? I do have a question. So given that it's a large manual, I know you have pretty comprehensive review on how to deliver the program. Are there efforts to make it more streamlined, especially if there's going to be trainers only focusing on a certain age group? Is there going to be an effort to just have a component of that packet?
Yes. So I'll answer this one, Sam, if that's okay. So our large document contains each grade breakdown, but we also have it built separately as individual documents, so that if you are a K through 2 PE teacher, you don't have to sort through 250 pages. You will have your 40-page K through 2 curriculum, which sort of has places to look up the different lesson plans, summaries for each lesson, so you can easily sort of decide what's going to be of benefit to you, and it'll be grade specific to the grades that each teacher is interacting with, if that's helpful.
Mikey, we got a question. It says, building the website is the easy part. What is the plan for maintaining it? I can speak to that a little bit. So we are actually, this week, we will hear back whether we were approved for a grant from the Michigan Health Endowment Fund. And we built into the grant is a continuity plan in which we would have, I believe, a couple people employed to continue moving on forward with this. And in the future, McKee, like he said, will be here in the gap year working on this project as a continuation. But as far as, far into the future, I'm not sure we even discussed that necessarily yet, but that is a good point that maintaining it will be a very difficult part. McKee, do you have anything else to add?
I think that was perfect.
Yeah, a lot is still, we'll know this week, like I said, whether we were approved for the grant, but whether or not we're approved, the curriculum is built and will be able to be integrated almost entirely with or without the funding, just because we think this is so important and we wanted to have it ready so that when we are approved for the grant, it can move forward seamlessly.
And Zoe, I saw your question and I'm happy to answer, but I do want to just be cognizant of the time. Dr. McKee or Dawn, I want to make sure that we save time for our other interns to present. Do we have time for one more question, or should we?
Thank you for the consideration, McKee. I think we do have just one or two more minutes, and then we'll move on to Kaila.
Okay, thank you. So Zoe, then to answer your question, Zoe said, have you considered finding a way to take the stories you mentioned and create an actual database? You're right that hits alone don't represent impact, but collecting stories as data can be a great way to get funding, encourage policy change, and engage stakeholders. We have not, so thank you for that comment, because you're so right, and that's so important. So this patient of Dr. Okunlami's actually sent us a recorded video, which we have, but I think moving forward, I'm gonna put that down on the list, and we're gonna try to make some sort of way to collect that. So thank you for that. I might be reaching out to you to ask if you have any ideas about how to do that as well. And thank you everyone so much, and thank you for listening.
Thank you.
Thank you, McKee. Thank you, Sam. It's a great presentation. I do want to mention very quickly that for a bit more information about our interns, there was a link included in the agenda. So if you want a little bit more about their background, please go there. In the interest of time, we're going to move on. I'd like to introduce next Kaila Helm. Kaila, are you all set? And I want to mention her faculty member or mentor, was Dr. Michael McKee. We can see you, Kaila, but I think you're on mute.
Hello, sorry, 1 second. I'm having a bit of trouble sharing my screen. One second, please. I don't know if Zoe maybe wants to start, maybe do switch order, because I have to fix my system preferences. It might take a minute.
Sure, I can do that.
Thank you, Zoe.
Thank you so much, Zoe.
No problem.
Sorry, I only did practice runs on Zoom.
Yeah, likewise, actually. Okay, let's make sure that mine will work.
I feel I owe all of the interns an apology on that. I also was, in my thinking, referencing Zoom, and it was kind of late this morning that we're all reminded that this is a Google Hangouts meeting. So we appreciate your patience. Okay, I will introduce Zoe, who worked with Dr. Lisa Meeks. And yes, we can see your screen, Zoe.
Okay, just making sure. Thank you so much. Hi, everyone. As Dawn mentioned, my name is Zoe, and I'm a rising M2 student at the University of Illinois at Chicago, as well as an MDisability intern. And I'll be presenting today on a thematic analysis of 16 interviews that were created for the DocsWithDisabilities podcast. I was advised over the past year and also for my summer internship by Dr. Lisa Meeks. And I want to be sure to express how grateful I am for the role that she's played in both my personal and professional life since I joined her lab. As I present, I'm going to be sure to describe each image on the screen just to ensure full accessibility. So on this screen, we have a background image of various animated people of different races and ages, each with a disability, including wheelchair users, folks using crutches, canes, seeing eye dogs, prosthetics, and more. I want to begin by sharing the context of the DocsWithDisabilities podcast that I was analyzing within the full campaign. On this slide, there's a timeline visually representing 3 events. In early 2017, Drs. Pamela Lau and Lisa Meeks launched the DocsWithDisabilities Twitter campaign as a method for sharing the experiences, both the positive and the challenging ones, of healthcare practitioners with disabilities. This small but growing population used the hashtag to share the barriers, gifts, challenges, and the beauty that they were experiencing in their training and their practice. In 2019, this Twitter campaign was transformed into a podcast in which Dr. Lisa Meeks interviews healthcare providers with disabilities about these experiences. Over the summer, I analyzed 16 interviews of the podcast to identify shared themes. And today, both the podcast and the hashtag are still growing, and a quick search on Twitter will uncover hundreds of docs with disabilities and their experiences. The current literature on the experiences of disabled providers discusses several barriers that are being faced. As written on this slide, these include lack of standardization of technical standards, which are often unfairly applied to people with disabilities, assumptions of incompetence, both during admissions and beyond, balancing the dual roles of being an ideal medical student, which unfortunately often means not prioritizing one's well-being, and being an ideal patient, which usually includes prioritizing one's well-being above all. And then finally, lack of mentorship opportunities with those who have similar experiences. The Docs with Disabilities campaign allowed disabled providers to share anecdotal evidence about the barriers already discussed in the literature and share experiences that haven't yet been included in the research. The podcast was developed to share these experiences and provide asynchronous mentoring for future and current learners with disabilities. My analysis aims to identify themes that arise when you consider the podcast and all of its interviews holistically, and to develop recommendations for both learners and the administrators that shape the learning experiences of those students. Included in this analysis were 16 total disabled healthcare practitioners. The majority of them had mobility-based disabilities. The majority are women. Most are MDs, and most are currently practicing clinicians. These participants were recruited by members of the Meeks Lab at the University of Michigan as participants for the podcast itself, and gave permission for their interview to potentially be analyzed later. Data collection for this analysis included semi-structured audio recorded interviews. This study design was chosen because prior research has shown it to be a strong format for obtaining a nuanced understanding of personal and sensitive information. It allows follow-up questions and conversation about unique experiences. There were quite a few questions that were asked during the interviews, and I selected just a few as sample questions, which are written on the slide. They include: what barriers did you face when pursuing your education/career? How have your patients reacted to your disability? And how can schools and institutions improve access and inclusion for learners with disabilities? The full interview transcripts were then created by the transcription service Rev and sent to myself and my co-researcher Swathi Metala. While the podcast episodes themselves, produced by Kate Panzer, are 30 minutes or less, we analyzed the full 60 to 90-minute interview transcript. Thematic analysis was then used to analyze the interviews because, according to Braun and Clark, it's an impactful method for exploring shared experiences and patterns of thought and behavior as they relate to that experience. As recommended by Kiger and Varpio, an iterative process of individually coding and then combining codes was used. When combining codes, and in the long run combining full themes, Swathi and myself had intentional conversations about overlap between codes, the relationality between them, our own personal biases, and more. When all 16 full interviews had been analyzed, 5 main themes were identified. As written on the slide, they include medical culture, stigma, accommodations, infrastructure and systems, and mentorship. Each of these themes was also broken into sub-themes, which I've included in the subsequent slides. The theme medical culture included the sub-themes impacting the culture of medicine, which was about the ways that disabled providers can really push the culture of medicine in a positive and more inclusive direction. Empathizing with patients about the unique ways that providers with disabilities' own experience with disability, illness, and healthcare can allow them to interact with their patients in really powerful ways. Patient as doctor, doctor as patient, about the ways that being both of those things influences one's medical practice. And not fitting the culture, about the ways that medical culture has certain expectations and a certain mindset that can create challenges for disabled learners and providers. As just one example, under the sub-theme, empathizing with patients, a participant said, "We can communicate without words. I 100% agree. I think it makes me a better physician. It makes me more empathetic and caring," when referencing his own disability. The theme stigma spoke to the various aspects of medical school life that can be impacted by stigma, including one's evaluations during admissions and beyond, one's decision to disclose, feeling that you might need to prove yourself as worthy of acceptance and investment, the decision to pursue accommodations, and how often one might be allowed to directly care for patients. Specifically, one participant captured the sub-theme desire or need to prove it by saying, "As a disabled medical student, I think people often forget that actually I have to spend 100% more time trying to be better than everyone else." In the theme of accommodations, the sub-themes included engaging the individual about the power of recognizing that a learner is the expert of their own needs. Transition to practice, about the challenge of using accommodations after you leave the classroom and you're now in a clinic setting, which you may never have been in before. Lack of information about how challenging it is to simply know what accommodations might be out there and how you can utilize them. Self-advocacy and the power of technology, about the ways that constant advances in technology can enable disabled providers in their practice. Under the theme lack of information, one participant shared that they definitely struggled with getting time off for doctor's appointments, and they realized later that was an accommodation they were entitled to, they just weren't always given. Under infrastructure and systems, heavy emphasis was placed on policies and procedures that are creating barriers for those with disabilities. This included policies about admissions, funding, research, accommodations, communication, and more. There were also sub-themes about physical accessibility and identity and privilege. One participant captured this latter sub-theme about privilege by saying, "That happens a lot in medical education, where if someone presents with an exacerbation, especially if a mental health issue, it is take a leave of absence, come back when you're better." And you know, for so many people, that assumes a ton of privilege. That infuriates me because, you know, people have different life situations. And finally, the theme of mentorship. There were 3 sub-themes: mentoring younger disabled students, importance of being mentored, and disabled communities, all of which capture how vital mentorship roles and mentorship relationships are, especially for underrepresented minorities in medicine. One participant stated that mentorship has in fact been the most important thing in her life. So in medical school, I was extremely close with my mentor, who had a really big influence on my life when I was deciding, you know, do I want to apply to these? Is it something I can do or not? Generally, the codes in this analysis mirror much of what current literature states. There are barriers, particularly attitudinal barriers, facing learners with disabilities in all aspects of their training. These barriers were experienced by all disability types, although it's important to note a limitation is that most people in this analysis had physical disabilities. And similar experiences were also experienced across different types of healthcare practice, although a limitation is that most people here were MDs. Of note, every single interview that was analyzed included a discussion of the strengths and unique abilities of disabled providers. With their experiences in the healthcare field, both as professionals and patients, disabled healthcare professionals have a unique understanding of the field that they work in. This can allow them to communicate with patients in powerful ways and to develop trust in ways that they may not be able to if they didn't have a shared identity with some of their patients. Overall, the presence and full inclusion, including in leadership positions, of those with disabilities can shift the current perceptions of disability in healthcare fields. I want to be sure to note that the shift is critical for both providers and patients with disabilities. We've already discussed that negative perceptions of disability can prevent acceptance and full inclusion in healthcare training programs. But it's also important to note that these negative perceptions can prevent disabled patients from fully accessing the healthcare services they may need. Patients with disabilities have often reported negative attitudes towards disability in their interactions with doctors and other professionals. And the manifestations of these negative perceptions can range from subtle, like condescending language, to fatal, like withholding life-saving care. While it should not be the sole responsibility of disabled providers to shift these negative perceptions, their presence and leadership is certainly a critical component of the much-needed change. From the themes in this analysis, specific recommendations can be made to both administrators and learners. For administrators, expressing a commitment to full inclusion and backing that commitment with policy change. Not only does the policy change matter, but if you're expressing that commitment publicly, students feel that they can trust you and they can come to you with feedback and questions and let you know what they need. Having information readily available about accommodations, support staff, etc., and having clear instructions for your instructors to make sure they know how to accommodate students or know who to ask if there's an accommodation that they're not sure how to work with. Disability should also be included in all diversity and anti-discrimination efforts. For learners, actively seek relationships with those who are also disabled learners in healthcare. This can enable the sharing of ideas, of advice, and can also lessen feelings of isolation. Developing self-advocacy skills, while it can be challenging, can also help you stand up for yourself when you encounter a barrier that you know needs to be eliminated. Finally, utilizing social media and online platforms are a great place. They're a great place to find resources, mentors, and supportive community, particularly when those feelings of isolation are really strong. Overall, this study deepens our understanding of the lived experiences of disabled healthcare professionals, allowing us to consider what changes actually do need to happen to shift medical culture in a less ableist and more inclusive direction. Using interviews that capture the lived experiences of those who are most impacted by these issues to guide inclusion efforts and cultural change is important not only because it's rooted in evidence, but it also follows the long-time disability mantra, nothing about us without us. Thank you.
Thank you, Zoe. That was great. Okay, we have just a few minutes if anyone has questions for Zoe, and then we're going to move on to Kaila. Are there any questions?
I have one, Kaila. Can you hear me, Kaila? Or Zoe, sorry.
Yeah.
I was wondering if you have any sort of ideas, and like the mentorship component of this, I think to me is so impressive and such a great idea to look into. I was wondering if you have any ideas sort of from this work and the other work you're involved in, to what extent are students with disabilities even discouraged from pursuing a medical career? You know, so how many, or any idea just of the number of students that don't even make it to applying to medical school, attempting to, you know, take on the pre-med curriculum, etc.
Yeah, that's a really good point, McKee. So I'm going to kind of take a two-pronged approach to answering that, one from the analysis and one from personal experience. In the analysis, so obviously this was a 12-minute presentation, but of 16 hours worth of interview. So I can say that the large majority of people that we analyzed, but also people who have been a part of the podcast beyond this analysis, there were only 16 interviews in the analysis, and the podcast has more than 16 episodes. It's very common for people to express that someone along the way, whether a student, instructor, administrator, parent, whoever, told them that they might not be cut out for medicine, that it's either going to be too hard for them and take too much of an emotional and physical toll, or that they're simply not capable, they're not smart enough, if they're, you know, I remember one story in particular where someone said, you know, my hands don't work well, so someone assumed that if I ever touched a patient, I would be harming them, you know, kind of assumptions like that. And as a person with a disability who is in their second year of medical school, I've already done the admission process. I was accepted. I'm here. I'm doing the thing. And I still have people all the time kind of question that competence and whether or not my patients will be safe with the way my body and mind work. But I do want to note that I have never once had a patient express that, even when I'm using my mobility aids. Patients have expressed a connection with me, a excitement that I quote unquote get it. You know, I get what it means to be in the healthcare system. So while I'm sure that there have been patients that have said inappropriate things to disabled doctors, I do not doubt that. I do think it's interesting that most of the stigma that I hear people report and that I have faced has been from fellow students and physicians, not from the patients themselves. Thanks for that question, McKee.
Thank you.
Yes, thank you, Zoe, for that incredible lived experience and sharing that input. Okay, with that, because we're getting short on time, I want to make sure Kaila has adequate time. Kaila, you are up.
Hello. Can you all see my presentation now?
Yes.
Yes. Okay, thank you so much, Zoe, for doing that little switcheroo. Okay, so hello, my name is Kaila, and today I'll be presenting my project, Understanding the Barriers and Facilitators for Audiology Follow-Up. So just to start off, I want to give a little bit of context about hearing loss in the US. It affects 16% of the adult population. It's the second most prevalent disability and third most chronic condition. There are two main types of hearing screenings. Some of them are more subjective in nature. That includes some self-reporting hearing loss. A patient might be asked by a physician, do you think you have a hearing loss? Or they might do a self-assessment known as the Hearing Handicap Inventory, or HHI. Some of them are more objective, like an audiometric test, and an example of that is a pure tone test. So why are hearing screenings so important? Hearing loss has a lot of adverse psychosocial, cognitive, and physical outcomes. And despite its high prevalence, it's usually clinically underdiagnosed. So just to give an example, only 20 to 22% of those with hearing loss actually obtain and use hearing aids. So it makes it really important to have really early hearing loss screenings. So my study really looks at the timeline of access to care from that initial hearing loss screening by a patient with their primary care provider to getting an audiologist referral and then seeing them and getting recommendations for treatment. So the study has three main questions, the first of which is, do patients feel comfortable being screened for hearing loss? Second, do patients follow up with referrals? So after they are given a referral for an audiologist, do they make an appointment and see that appointment through? And last, do patients follow audiologist recommendations? A lot of audiologists recommend a wide range of things, but what are the facilitators and barriers for making that recommendation something that the patient could look into? So this study is a secondary data analysis from the EAR-PC study, the early auditory referral primary care study, and data was collected from 2017 to 2019. It was a feasibility study in which clinicians received a brief educational program and an electronic clinical prompt to screen for hearing loss during applicable patient visits. The patients separately did HHIs, and they wanted to see if the prompt would increase audiology referrals for at-risk patients for hearing loss. The study population included patients aged over 55, and they had an HHI greater than 10, which indicates probable hearing loss. The study included patients randomly sampled for a 3-month follow-up telephone survey. So these included questionnaires with open-ended notes. The statistical analysis was mainly univariate analyses based on the survey responses. So it's very descriptive in nature, mainly looking at frequencies of different responses. And then there were open-ended comments that were qualitatively coded, and the themes were then categorized separately by myself and my faculty mentor, Dr. McKee. And then we checked for agreement. And then I created a coding dictionary that was used for categorizing the themes. So my first question was, do patients feel comfortable being screened for hearing loss? And I looked at that in 2 different ways. Patients' perceptions towards hearing loss discussion, as well as their perceptions toward receiving a referral. So when patients were asked, do you remember how you felt about this conversation? A lot of patients had a positive reaction, saying that they were glad. And those who didn't, it wasn't like the other 40% just had negative reactions. Most just had no opinion. And then patients had an opportunity to discuss their thoughts further through the open-ended responses. And you might notice here that the ends don't agree. And that's because not all patients that answered the categorical question then gave notes about their other thoughts. But in looking at the results, a lot of patients kind of discussed how either they were dealing with something in their own personal life where their hearing loss was really impacting their quality of life. So they went into that appointment really wanting to talk about that. It was more a really patient prompted hearing loss discussion. And others, they remarked how happy they were that their provider had been asking them questions about their hearing loss, which really opened up room to discuss something that they didn't realize was so negatively impacting their life. One patient talked about how her hearing loss was something she had been dealing with over a decade, and her husband had been so understanding, but she was really relieved and impressed with the quality of care that she had. So looking at the referrals, 284 of the patients actually received referrals, and they were again asked, how did they feel about receiving a referral to audiology? And similarly, a lot of patients had a positive reaction. Those that didn't just had no opinion. And when asked to elaborate on their thoughts through that open-ended response, a lot of patients said that they planned to see an audiologist, but interestingly, a lot of them just had like a general positive attitude toward a referral, but many specifically discussed how the referral was really addressing some of the priorities in their life and the ways that their hearing loss was impacting them. One patient said that his wife really thought that he had a hearing problem, but it was really nice for his doctor to bring that up and create an environment that he could speak about it and then receive a referral. The second question was, do patients follow up with referral? So what happens in between scheduling an appointment and actually seeing an audiologist? So patients were asked if they had made an appointment and then later seen an audiologist. And in purple, you could see that 75% of patients made an appointment. In green, 63% saw the audiologist and 12% made an appointment and they haven't seen an audiologist yet. Some described missing their appointments because of time demands. Others may not have just seen their audiologist. And then they were asked why they chose not to make an appointment. And a lot of patients remarked how cost, no insurance coverage, and competing health, time, and family demands really was the main reason why they couldn't. For example, one patient said they just can't afford to see an audiologist because insurance doesn't cover it. Another that they were dealing with a lot of physical issues that were more important at the time, and maybe they would go again in the future. And then for the last question, do patients follow audiologist recommendations? So when patients do go see an audiologist, many are given recommendations. They range from being recommended hearing aids, further testing, to return again in 1 year, or that their hearing is just not severe enough to do anything at that time. So patients were kind of asked, how do they feel about these recommendations? And a large percentage, 63%, had positive reactions with plans to follow through with the recommendations. And others were mainly undecided about their future plans. So patients were asked if they had not already taken the recommendations, why not? And again, something that came up was the impact of cost and lack of insurance coverage. One patient said that when they learned about the cost and found out they didn't have insurance coverage, they just decided that their hearing is not bad enough at that time for them to be able to continue to figure out how they could treat it. And looking at those that are recommended to receive hearing aids, only 42% actually received them. Patients that chose not to get hearing aids were asked for their reasons. And again, something that came up was cost, amongst other reasons. And one patient said that they would love to get hearing aids, but that simply is not an option for them right now because it's not covered by her insurance. So this leads me to discuss some of the main project findings. So there are a lot of different facilitators and barriers to audiology referral follow-up. Some of them, facilitators, include that positive provider engagement. How was that initial conversation that patients had with their primary care provider? And another would be family encouragement, and talking a lot about some of the patient responses. A lot of them talked about how their family was really encouraging them to see a care provider and find out if there's ways to treat their hearing loss because it was impacting their life so much. And some of the main barriers were cost and insurance coverage. A lot of patients talked about how they would love to get hearing aids, but they can't afford to. And many talked about competing health priorities, that when you're just dealing with other health concerns that are more pressing, it makes it harder to address hearing loss. There's a few limitations of the study. For one, generalizability. A lot of the patients were predominantly middle class, white, and aged over 55. Also, this is only 2 family medicine clinics in Michigan where the data was collected, and not all patients provided open-ended responses. So although I was able to create category dictionaries and really get an idea of some of the patient feelings and perceptions, this didn't include all of the patients that answered the previous categorical questions. So I think overall, there's a lot of different implications that this has on policymakers, health systems, and providers, that there are just a lot of healthcare access issues, and there are different levels in which these could be addressed in terms of the impact of cost and insurance coverage, and making sure that initial conversation with the provider is one that is really conducive to talking about your hearing loss. So just to conclude, some good summary points is that not all of the patients that received referrals actually saw an audiologist and then took on their recommendations. So of the 284 patients that received referrals, only 178 actually saw an audiologist. I think a major takeaway is that there are many patient, health system, and provider factors and patient factors that influence the ability for audiology follow-up. And some of my plans for future research include focusing more on the impact of cost and insurance coverage on this healthcare utilization, but also following the patients longitudinally through the data set. For all of the questions I was asking, I was looking specifically at each question and not really connecting how that initial provider conversation influenced the ability for a patient to then, see the audiologist and get a recommendation. So kind of looking at it through the data set would be really interesting, or doing like an additional follow-up at 6 months or more. So that would be interesting as well. So I just want to thank everyone from the MDisability team. I had a wonderful time doing this internship, as well as the other interns and all of the speakers we had at our various journal clubs throughout the summer. This is some of the citations from my introduction. And now if you have any questions, and I know we only have a few more minutes, so if there isn't enough time and you want to ask me one, this is my email.
Thank you, Kaila. So let's open it up for questions, and then we'll do a wrap up. Again, thank you. So let's go ahead and see if anybody has any questions, either by chat or if they want to unmute themselves and ask a question on audio, that'd be fine too. Okay, I guess nobody has any questions. So, Kaila, you probably did a great, really just address a lot of the concerns that everyone had. So again, thank you for the excellent presentation. I also just want to thank everybody who've already presented, McKee, Sam, and Zoie. Thank you for the wonderful presentations. This is just highlighting the robust collaboration that all of us have. So I'm really thankful for everyone putting the effort and working together with our summer interns. And even though we're coming to the end of this summer internship, but this is really just the beginning. And this often leads to long-term collaboration. So I'm excited with what's gonna be happening in the upcoming year, working with each one of you, and also your career endeavors as well. And I also wanna thank the opportunity for the funds that we received from Dr. Sasso in the chair fund package, as well as just supporting the MDisability. Without those funds, this would not be possible. And really just to have the opportunity to generate a pipeline of future researchers, clinicians around disability health. So again, thank you for the wonderful presentations. And I'm sure many of them are also willing to address questions offline by email as well. Thank you again.